So, methods analytics. Just a very brief overview about us. We were orphaned with the disorganisation of the NHS in 2012 when the East Midlands Health Observatory was sort of abolished, which is what we were. And out of that, we took a team into the private sector to specialise in healthcare analytics and data science. So since then, it's been quite a long old road. I think we're probably one of the larger organisations here today. We've diversified into the broader public sector as well as away from health, as you'll see shortly. But we've made our living out of doing data science for the healthcare service for most of that time. This is something which is kind of where we started, way back when. So this has since been superseded by sort of NHS England and others' internal systems, doing benchmarking, statistical process control against sort of all the various hospitals in the country. So this is our sort of origin story, for want of a better term. So I'll talk to you through some case studies that are particularly relevant, hopefully, to people in the room today. I could talk about GIRFT. Sorry about the resolution on that. We've worked heavily with the GIRFT national programme, identified huge numbers of savings, helped them build up some of their programmes from the ground up, supporting them on all sorts of aspects. I could also talk to you about papers we've written on emergency medicine and the effect of waits beyond 4 hours on mortality, which has caused some rumblings, it's fair to say. Could also talk to you about work that we did with the Care Quality Commission about trying to use natural language processing. This is just a sample, it is not from any of their work, to try and enhance the way that they do data collections and examinations of data to make sure that they avoid their big concern, which is missing something. For someone like the CQC, with all the inbound communication that they get, their biggest concern is not picking up on something which turns out to be materially significant. So things like natural language processing applied to emails or messaging that's inbound is actually a really good way of them potentially categorising and pulling out things of concern or thematic concerns over a period of time, which humans just looking at things in isolation are less likely to pick up. So I could talk to you about those things, but actually my first case study is going to be somewhere totally unexpected and not related to healthcare at all. And I'll explain why. Inappropriate inventory disposal analysis. Strange topic to talk to healthcare people about, right? This is, again, not from our service designers would kill us if they could see that on screen in terms of the organisation. That's someone else's diagram, not ours. But it's there to give you an idea of the complexity of the sort of systems we're talking about. So inventory disposal in this case is a Ministry of Defence concern. So when they get rid of equipment, some of which goes bang, they prefer it to end up with very specific people and disposed of appropriately. Now, one of the big things that we always talk about in healthcare analytics is the huge complexity we have. All the different systems that we have, and we go, oh no, this is the real problem. It's putting it all together. Actually, for me, one of the biggest problems you have is getting the will and the buy-in and everything else to do something ambitious, to do that integration, to look at the problem at a very macro level. And that's one side of the equation. The other side of it is the truth of the complexity, which is that data about humans used to do other things to humans is fundamentally complicated and fundamentally is quite weak for the sort of decision making that we try and associate with it when it gets really, really grouped up. So that's the real problem. But when we worked through this program here, we had something like 27 systems. We had worked with a huge number of suppliers. Now, these suppliers want to collaborate even less than the collaborators. People want to collaborate in healthcare and share data in healthcare because they're actually got a vested interest in not sharing this data. For them, it is their edge for why you would buy from, I don't know, Thales rather than BAE. Hugely important data for them to keep to themselves if they possibly can. But if you can do these integrations, so 29 internal systems, 17 industry systems, 8 data sets on top of that. So those data sets are collected separately entirely, not from systems. They're not systematically collected. There's no ontology for any of these things linking them together. All of this stuff had to be built up. But if you go through these sorts of processes, the standard data science processes that we all, or at least most of the people in the industry understand, so a totally standard approach, regardless of problem, you can get 664 million unactioned disposal from a single hypothesis, 18% higher than client's estimate. So 18% more than the client thought they were going to find just from their own analysis. That's one hypothesis. We did 5. There were over 20 beyond that. Now, we're starting to talk real money at this point, and all of this is possible because we were given the opportunity to do something that was extremely ambitious. And the client was very interested in looking at the whole picture. We have a tendency within the healthcare space to focus quite narrowly, and that's often for good reason. But I think some of the things that are missing and some of the things that kind of don't get done are the things that are ambitious. And that is because of the legacy of things like the failure of MP Fit and the legacy of things like the fact that ICSs, which should have been in place 2.5 years ago, are only just finally in place. We don't get things done quickly enough to move at the pace that industry wants to move, and that is one of the biggest reasons and the biggest challenges that we have. So let's look at something a bit smaller. So we as a company work on really, really big things. We work on really, really small things because data science is a very broad church, and it needs to be to get any kind of good decision making. That means diversity of people, that means diversity of perspectives, and it means diversity of projects. He says, checking his watch. So this was a piece that we've done very, very recently with our collaborators UHL, funding from NIHR, a route that a lot of you will be familiar with. So this is to say, even as we are as a company, as a bigger company now, we still work at both ends of the spectrum and think it's really important to. This is the approximate number of complaints the NHS receives per year. It's quite a big number, and I don't just mean the font. That's a massive underestimate. I think most people in the business would agree. Those are just the formal complaints. Those are the ones which go all the way up to the top. This is not concerns. This is not communications which look actually are a complaint but aren't through the right mechanism. This is just the ones which will really get actioned. Now, working with NIHR, as we said, to fund a natural language processing investigation into whether or not we could look to improve complaints triage, make it a bit easier. Because one of the things that people find when they work or in healthcare is that if they give a complaint, it gets dealt with sometimes very effectively, sometimes not. But the most important thing for patients is to be heard. We know that we get complaints where it is not a material concern, it is to do with their feelings on the matter of how they've been treated. But you still need to respond to that. That is still a valid concern. That is still something that we have a responsibility to respond to. But how do you sort those things out? How do you work out which route people should go through? That's where triage comes in. Obviously, one of our partners is in the room today, which is always very nice. Minimal viable solution to meet UHL's requirements. And UHL's requirements were pretty simple, which is, can we make this faster? Can we give some decision support to the people who slog through these complaints on a regular basis? That means bringing together lots and lots of skills. This is the one that people say, oh, yes, this is the sexy thing that everyone wants to do and is really important. Everything else around this is just as important. You want to build a multidisciplinary team. Data scientists is not clever people in rooms doing things behind closed doors and in the dark. It is a team sport. So, identifying and standardizing some key themes, running through topics, started off with 30, which is far too many for any of you who do that sort of analysis, trying to remove some subjective judgment from the topic assignment, working with individuals who are expert in doing this sort of thing to work through these topics, so using pretty standard natural language modeling techniques. 1 minute. This is just some quick sample outputs. There's a lot more to it than this, but it's currently just in its final stage of being reviewed by NIHR, so I can't share too much. But I think anyone who's worked in a hospital would not be surprised to find that discharge and medication are the things that most people most often complain about, because everything at the end of the process when you go through a secondary care unit it tends to be sort of a little bit on the last minute. It's just the nature of the business. But this is pretty simple in terms of thousands and thousands of complaints pulling down to 10 topics which you could immediately kind of break down. There's also this particular piece, which gives you, again, something which in the complaints space people don't tend to have, which is just some management information about when complaints come in, and then being able to drill through and look at the individual complaints behind it, and then look at maybe the topic that's behind the complaint, and then think about whether or not there's some themes there which they need to look at and could have some impact on sort of the business as a wider piece. Because, for instance, you'll see that complaints here, 2020, Q2. Any ideas why there are fewer complaints? So there's really, really simple pieces like that which will drop straight out of the data. That potentially also means that if you're thinking about this in the right way, you might want to look really carefully at those complaints, because those people sure as hell need to be in hospital. I don't think there's a debate there. So do you need to look at those more carefully? Can you prioritize them? And can you use things like NER, which you also applied to this, to actually pull out specific blocks of text within the complaints themselves and semantically match them to other ones and see if you can do some thematic analysis that way as well. So that's a very brief overview of us, some of the work that we're involved in. This is a slide my Director of Delivery always insists I have because we are hiring. We're always interested in meeting new people who would like to work with us or near us or for us. So thank you very much.